The next section we want to talk about is care of the postpartum patient, or after delivery care. And let's talk about what we need to do for mom. We need to assess the uterus. There are some landmarks that you need to know about. 1 hour after delivery, the uterus is, or the fundus of the uterus is usually about the level of the umbilicus. It then rises, so by 12 hours after delivery, it's about 1 centimeter above the umbilicus. And then it should descend at least 1 centimeter a day. So by day 5, it's 4 or 5 centimeters below the umbilicus. By day 10, it's below the symphysis, and you can no longer palpate the fundus of the uterus. By 6 weeks, the uterus has gone back to its pre-pregnant size, and we say that involution is now complete. Now remember, at the placental site, this is a big, gaping, open wound. And that's why we need to massage the uterus if it is not firm, if it is boggy, so that it can contract and stop the bleeding at this gaping open wound site. Cramping is felt by most multipara, oftentimes by a primipara, a woman with her first delivery. Remember that the cramping that occurs after delivery usually gets worse with every baby, so by the time you're down to baby 5, the after pains are really much stronger than they were with babies 1 or 2. Breastfeeding increases oxytocin production, so that will cause more cramping. 6 hours after delivery, the nurse notes that a woman's fundus is 2 finger breadths above the umbilicus and deviated to the right of midline. The nurse suspects the client may have which of the following: retained placental fragments, bladder distension, begun involution, or second-degree uterine atony. And the answer is number 2, bladder distension. The most common cause of a rise in the umbilicus, not the umbilicus, a rise in the fundus of the uterus, and deviation to the side is a full bladder. So have the patient void, and you should see the uterus come into the proper position. We also, I think you should know about lochia. And remember the color changes that occur in lochia. Lochia is the drainage that we see following delivery. So for the first couple of days, 2 to 4 days, it's lochia rubra. It's red. It's bright red in color. After about 3 or 4 days, from about days 4 to 10, we're going to see lochia serosa, where it's a brown or a dark red in color. And then it becomes lochia alba, where it's white or yellowish discharge. And this may continue for several weeks. Prolonged lochia rubra would suggest slowed involution or retained placental fragments. So if it lasts longer than 2, 3, 4 days, we get concerned because the woman may have retained fragments. Or if she starts lochia rubra at, say, maybe 3 weeks or so, it goes back to a lochia rubra. This is a cause of concern. It could be retained placental fragments. And a couple other things. If we talk about what changes occur in the urinary system, we mentioned that a full bladder was the main cause of uterine atony. We just did a question that related to that. Oftentimes, voiding is difficult immediately following delivery because of the pressures that have occurred in the area. That should clear up fairly quickly. Diuresis tends to start about 12 hours after delivery and can last for up to a week. This is one of the ways that we get rid of that extra fluid, that 50% increase in blood volume that mother had by the end of pregnancy. She also will probably have a diuretic phase as well, and a diaphoretic phase. Make sure she has plenty of fluids during this time. We want to think also about the emotional adjustment to women, or of women after delivery. Usually for the first couple of days, the women are rather passive and dependent, and they'll do what you tell them to do. You tell them to take a sitz bath, they'll do it. They start looking at their baby and do fingertip touching, so they poke the baby here and there. After a while, they will envelop the baby and hold it tightly. Usually about 3 days, 2-3 days after delivery, and it could last for another week or so, is the stage of independence. And this is when mother wants to prove to her mother-in-law that she is super mom. So she tries now to not only take care of the newborn, clean the house, make the meals, host her mother-in-law, and take care of the other children, and then she collapses with fatigue and tears. But this stage of independence, when mom really reaches that independent stage, it's sometimes time for mother or mother-in-law to clear out and let her now take over running of the household. And the letting go phase is when we really recognize the baby as a separate, independent being. It's particularly with first babies, you notice this a lot. When the babies first are brought home from the hospital, everything is baby central. There's diapers everywhere. They don't know where the changing table is going to be. Everything is baby stuff. After a few weeks, what happens is things get into a perspective. They're never going to be like they were before the baby came. But there's now a place for the diapers, and the baby is really integrated into the household routines. This is letting go. A question for us. A newly delivered woman has chosen to bottle feed. Which should the nurse include when instructing her about caring for her breasts? 1, take long warm showers letting the water hit your breasts. 2, massage your breasts every 3 hours to increase circulation. 3, wear a supportive bra and do not handle your breasts. Or 4, hold your baby away from your chest so he will not smell your breasts. And the correct answer is number 3, a supportive bra and minimal handling of the breasts. If she is bottle feeding, we do not want to stimulate milk production. We would encourage her to put cool cloths on as engorgement occurs. The breastfeeding woman, we would want warm cloths, a warm compress. Let's do another question. A pregnant woman tells the nurse she is going to breastfeed because, quote, you can't get pregnant while breastfeeding, end quote. What is the best nursing response? 1, lactation does prevent ovulation. You shouldn't get pregnant. 2, you cannot get pregnant if you don't menstruate. 3, when a woman is breastfeeding, she may ovulate even if she doesn't menstruate. You should use some form of birth control. Or 4, you probably will not be interested in sex until after you wean the baby. The correct answer is number 3. Remember, when women are breastfeeding, they are less likely to get pregnant, but it's by no means a contraceptive measure. Some women, when they are breastfeeding, will menstruate and not ovulate. Some women will ovulate and not menstruate. Some women will do both. Some women will do neither. But breastfeeding is not a reliable means of contraception. Now let's talk a little bit about breastfeeding. This is an absolutely wonderful system. The more the baby sucks, the more the baby drinks, the more milk is produced. So this supply and demand system is a beautiful system. Usually the first few days of breastfeeding can be difficult for mom, particularly for the new mom. Remember that engorgement occurs about 48, 72 hours after delivery, and engorgement is when the milk comes in. And the breasts are really firm and large and painful and warm at this point. This is probably the most difficult part of breastfeeding. Once you get past the engorgement phase, breastfeeding is usually a much easier process. Remember that if mom is breastfeeding, we would encourage warm compresses to the breast during the engorgement phase. If she is bottle feeding, cool compresses to decrease the milk production. Babies can nurse for a number of minutes at a time when they first start to breastfeed. The length of time they are nursing will increase as the babies grow in size and need more milk. They might ask you questions about nipple care. And remember that prior to a delivery, sometimes we have women say take a Turkish towel and gently rub the nipples. That tends to toughen them up a little bit. If the woman should develop painful nipples or bleeding nipples, she might be able to use a little device that goes over the nipples, a nipple shield, that will reduce the pressure on the nipples while they heal. It puts a little suction on it so that the milk will come out and the baby will still get the milk, but it's not direct pressure onto the nipples. I think there's been a question on the exam that asked about nipple care. The fact that after breastfeeding you'd want them to wash off the nipples and let them air dry. They have also asked, I think, about mastitis. So a woman has an inflammation or infection in the breast. And the question is, can she continue to breastfeed? And the answer is yes. In fact, that actually helps to clear the mastitis. If she needs an antibiotic, she'll be given one that's not going to be dangerous to the baby, because of course the baby will get it. I would suggest that as you're teaching moms about breastfeeding, you remind them that whatever mom takes in, baby gets. So that if mom drinks lots of coffee and tea and caffeine and Coke, baby is going to be hyper and alert and not sleep very well at night. So have her be alert to that. We also know that if she eats a lot of gas-forming foods, sometimes these go through to the baby and make the baby have colicky-like symptoms. So she needs to be a little bit careful about what she is eating, because baby gets it. The nurse is caring for a woman who delivered a baby 3 hours ago. The woman calls the nurse. The nurse finds the woman lying in a blood-soaked bed. What is the best initial action for the nurse to take? 1, assess and massage fundus if soft. 2, take vital signs. 3, place the woman in sharp Trendelenburg position. Or 4, notify the physician immediately. So the best initial action is going to be number 1, assess and massage fundus if soft. Because the most likely cause of bleeding at this point in time is likely to be a boggy fundus. So we would do choice number 1. Later you can take the vital signs. If massaging the fundus doesn't stop the bleeding, then you could call the physician. Mathergin 5 milligrams QID is ordered for a postpartum client. An hour after taking the drug, the woman complains of uterine cramping. What is the best explanation for the nurse to give her? 1, this is an unfortunate side effect, but you need the medicine. 2, the cramping is uncomfortable, but it's a sign the drug is keeping your uterus contracted so you won't bleed too much. 3, since you are experiencing cramps, I'll ask the doctor to discontinue the medicine. Or 4, the cramping should stop soon. If it does not, let me know. I'll ask the doctor to lower the dose. Now, in order to answer this question, you need to know that Mathergin is an oxytoxic and it causes uterine cramping. And the best answer is number 2. The cramping is uncomfortable. Recognize that for the patient. And then tell her why that she needs it. It's going to keep her uterus contracted so she won't bleed too much.